My name is J.D. Kleinke. I'm a freelance medical economist and author and involved in a number of healthcare information technology startups. I'm here today at the HIT Summit in beautiful Palm Springs, California. My presentation today really focused on what's really in the healthcare reform law versus what people think is really in the healthcare reform law. There's a lot of political noise, there's a lot of gnashing of teeth, there's a tremendous amount of ideology involved in the debate to the point where people have completely lost focus on what's really in the law. These folks are working day to day in the trenches of healthcare, both on the provider side as well as the health plan side, so they need to know they don't need to know a big political argument or have a big political argument. They need to know what to do next. They've got to run groups. They've got to figure out budgets. They've got to make really important decisions about, do we take financial risk? Do we build new kinds of computer systems? How do we market our organization to people? That's the stuff we focus on, not the ideology or the politics. Well, it's actually neither. What we have today in the healthcare reform law is very much an extension of the status quo. It's a employer-based, mostly employer-based or Medicaid-based, commercial insurance company mediated fee-for-service healthcare system. It just takes the system, as most of us are already included in it, and it forces it open in the case of a lot of people, so that everybody has to participate. People who are too sick and haven't been able to participate, people who are too headstrong and reluctant and just didn't want to participate, or people who are just too poor and couldn't afford a way in. So what the law does is it provides three different pathways for people who have not been participating in the system. And that's been putting a huge amount of strain on the system and making the rest of it dysfunctional for decades. So it's a long overdue fix, but again, to the status quo. I think healthcare change comes very slowly, but the change that does come is profound and permanent. Whether that's the computerization of medicine, or that's hospitals and doctors starting to work together as teams, or patients recognizing that there are economic consequences to their choices. Those are the big changes. They have been decades in coming, and there's nothing in the health reform law that lessens any of those, and in fact probably accelerates all of them, because it really is, again, just an extension of the status quo. Well, the single biggest challenge that people in information technology have to face is tremendous budgetary pressure. They've got to figure out what's real and what's not. They've got limited resources, they've got limited time, they're trying to do 100 things at once, and there's a lot of temptation to overreact, to react to the politics of health reform, or the belief that this newfangled thing proposed in the law is going to be here tomorrow. None of that's ever true in healthcare. We are constantly reacting to these impending crises that never quite get here. So the hardest thing for an IT executive today is to have the discipline to recognize that there's a lot of noise out there, and what they need to really focus on is what in that noise is real and permanent and on a very long historic trajectory, not a daily or weekly or even monthly wiggle with the news. Well, payers and providers for many years have been on opposite sides of the great patient divide, fighting over money, and that is the source of a lot of conflict and a lot of dysfunction and a lot of inefficiency. That's how medicine got started decades ago with insurance. That is something that everyone who thinks about this problem has known really since the 70s and into the 80s, and that gave rise to managed care, is that if we could get providers to start to think a little bit more like payers and start to think a little bit more about cost, and to somehow, and we could never get right, and we're only now starting to get right, if somehow put aside this self-interest, which is to just do more for the patient, even if it's wrong, even if it's not necessary, even if it's the more expensive course, to put that aside, to put the payer hat on and to start to think that way. Then no one's going to do that voluntarily. The only way it works is when payers and providers actually start to cooperate, exchange real money over that, and get their incentives put together in the right way. It's been a long time coming. My final thoughts on all of this is that this will not be the end of the world. I've seen the end of the world several times over in my healthcare career. Despite all of that, and we're talking managed care or consumers having to pay new co-payments or a bad debt crisis, healthcare does go on. Medicine does get better. Doctors get smarter. We do computerize healthcare. Patients do get better, more active, better at advocating for themselves. None of it's perfect. None of us are going to be happy till it's closer to perfect, but we do make progress. We make tremendous progress on the medical side, and it's important not to lose sight of that. What it means to be a patient today, to have a disease like cancer or HIV or depression or lupus or on down the list, it's a radically different experience today, thank God, than it was even 10 or 15 years ago.